This is the first of a series of trainings that DOHMH is offering to supportive housing providers, and we hope that this becomes a really helpful resource to everyone now and down the road as well. And so the first training is about our single point of access system for our mental health services in New York City. We recognize that there's a great need for different types of mental health services, and the landscape is complicated. And so this is one way of accessing some of the mobile treatment services that we have in New York City: assertive community treatment, intensive mobile treatment, care coordination, non-Medicaid care coordination, as well as some connections to the Medicaid care coordination for folks who have behavioral health concerns. And we'll learn a little bit more about what the eligibility looks like for those, as well as how to make a referral. We recognize that going into a system and learning a new system could be part of the obstacle at times, and we just want to make sure that everyone has a sense of what to expect when they go to make the referral. We'll make sure that there's plenty of time for Q&A at the end. So in the interim, please, if you haven't already, please plug in your email address. In the chat, we want to make sure to have everyone's contact information. We'll also disseminate this to our network who forwarded you the invite and or who sent you the email. So we'll make sure it trickles to those who are here as well as those who are not in some form or fashion. And so without further ado, I'm going to turn it over to our SPOA team here at the Bureau of Mental Health. Ghislaine, thank you so much. You're up.
Okay. Good afternoon, everyone. My name is Ghislaine Posey. I'm one of the clinical care coordinators here at SPOA. So happy everyone was able to join us on this rainy Thursday. I'm going to be one of the presenters today, and I'm also joined by my colleague here, Novelette. I'll give her a chance to introduce herself as well.
Hi, everyone. My name is Novelette Massey. I am the administrative coordinator for the Office of Treatment and Care Coordination and conduct the SPOA trainings.
I also know my supervisor, Daria Rosa, is supposed to join us. I don't know if she's on the line currently. I wanted to give her the opportunity to just introduce herself.
Yes, hi. Hi, I'm here. I can see everyone. Hi, Daria Rosa, SPOA supervisor. Thank you so much for everyone coming and joining.
Thank you so much, Daria. I'm just going to reiterate something that Kathy said. We have a lot of people that's in the space with us today. So if you're not speaking, we ask that you kindly remain muted so that we can make sure that everyone hears the information that we're going to share, because we have a lot of information to share with you today. And like Kathy said, all that information will be sent to you. So don't feel the need that you have to jot down every single note. We will send that for you, and all the questions. So we ask you to hold all your questions because we're going to have a QA session at the end. This is a two-part type of presentation. So we'll have a 5-minute break in between. So an opportunity for you to stretch, grab some water, and refresh yourself for the live demonstration part of our presentation. But all questions will be filled towards the end. And I just ask that, everyone remain muted. Unless you have something to say, you could raise your hand or something, and then we'll call on you just so that everyone can hear all the information that we are going to share. And we have a lot of information to share with everyone today. So we're just going to jump right in and kind of go over our agenda today. So if you can move to the next slide, please. So on our agenda today, we're going to talk about, all the SPOA accessible services that we have. We're going to talk about mobile treatment. We're going to talk about non-Medicaid care coordination, and we're going to talk about how to navigate the actual portal within itself, right? And some of the learning objectives is that after this training, you and everyone on this line should be able to successfully complete an application, right? You should be able to have a better understanding on how the referral process works itself, and have an idea in terms of the criteria for ACT, FACT, SPACT, IMT, and non-Medicaid care coordination. And then after the training, you'd be able to know who to contact if you need, let's say, technical support or any type of assistance. So aside from SPOA services, we know that there's a great variety of services that are available to New York City residents. One of the great services that became available recently is the 988. I don't know if everyone's familiar with that. It has replaced the NYC well. It's a lifeline that's available 24 hours. It's free confidential support for any individual that's feeling some kind of distress. Maybe they're having suicidal thoughts. Maybe they need some mental health support or some substance use crisis support. This is a great tool that you can use. I would advise you posting a flyer in your location so everyone knows, because someone can call, they can text, or they can chat with a professional through the 988 suicide and crisis lifeline. It's a great resource, and I advise everyone to kind of use this resource. Now to our services, SPOA. SPOA has been in existence, I would say, from 2002. We manage about 350 applications per month, and that's fast growing. Like that number is greatly growing as we add more services to our repertoire. We manage an array of in-field-based mental health or behavioral health treatment programs in care coordination. Another thing that we do is we determine the eligibilities for ACT, FACT, Sheltered ACT, or SPACT, as we like to call it, IMT, and non-Medicaid care coordinators. We assigned individuals, based on where there's availability, and that's appropriate for their level of care, right? We also connect persons to assigned providers, and we make referrals from our SPOA accessible services. Now, anyone can refer someone to SPOA services. The only thing we require, though, is a psychiatric evaluation and a psychosocial. We'll get into that a little bit later in terms of the documentation that we're searching for, but we would require those type of documentation, right? But there's no insurance. There's no insurance required to access services through SPOA. Another thing that's been coming up, as we know, we've been getting a lot of our migrant population. Status is something also we don't look at, like immigration status. So no insurance, no immigration status requirement for us. You just would have to have some type of a SMI for us. So in terms of our team, I'm one of the 6 clinical care coordinators. In my capacity, I basically review all the incoming referrals to determine the appropriate level of care and make the assignments to the providers that have vacancies, right? And we are supported by 2 amazing administrative assistants. They basically field all your calls and emails, and they handle all the administrative tasks that we unfortunately can't get to. So if you're reaching out to SPOA, you're probably reaching out to one of our admin staff. Now, let's transition to the services. One of the most intensive and one of the most innovative services that we have out here is the intensive mobile treatment, or IMT, as it's called. It's an innovative interdisciplinary team that provides mental health and substance use treatment, including medication. It supports people with serious behavioral health concerns and complex life situations, right? Someone who's transient or involved in the criminal justice system. The teams basically stay connected regardless of the person's location in the shelter. They might be in the street. They might be in housing, in the hospital, or in jail. They basically provide assistance with securing them with medical care, benefits, housing, and community supports. They also offer peer services and assist them with support for individuals with any type of lived experience, right? For peer advocacy. If we can mute ourselves, if we can remain muted, please. Thank you so much. Now, individuals who are connected with an IMT team, they get visits. An SMI presentation. Give me 1 second. I think we lost the presentation. I want to make sure that we're able to see it.
Oh, we can see it on the screen.
Okay. I can't see it on my screen, so now let me just click yes. Thank you so much.
Okay.
One of the things about IMT as well, there's no insurance requirements for it. And it basically operates on a 9 to 5, and there are some after call hours, on call hours as well. Now, what are the requirements, right, for IMT? One of the things we're looking at is if the person resides in a New York City shelter, maybe they're street homeless or have housing that is highly unstable or in jeopardy. Maybe someone who's, subway homeless, or be difficult to locate because they, due to frequent stays with different, services. Maybe they have recent and frequent contact with mental health and criminal justice systems. And one of the major things with INT is we're looking for recent behavior that is unsafe, that is escalating with greater frequency. That can be violence or threats of violence. And for this individual, traditional forms or all the other things have not been able to support them and have not met their needs. So they would need a higher level of need, which is why IMT would be a most suitable service for this person. Another service that we have that is also known as well is Assertive Community Treatment, right? It's an evidence-based treatment and rehabilitation services for individuals with serious mental illness and needs that have not been met by traditional, mental health services. There's an interdisciplinary team that provides services to individuals in the community. It could be at home, it could be in the shelter, right? You'll have, your counselors, you'll have your substance use, and an individual that gets an ACT team is visited approximately six times per month. Now, in terms of ACT services, I do want to put that disclaimer out there. If an individual has a primary diagnosis of a personality disorder, substance use or substance-induced diagnosis, a TBI, or have some kind of a developmental disability, they are not the most appropriate for ACT services. So if you have an individual with those diagnoses, I wouldn't recommend putting in a referral for ACT services, where they might be suited for IMT, depending on all the other things that might be showing up for the individual. It wouldn't be appropriate for ACT. I would just want to put that disclaimer out there. In terms of the eligibility criteria for ACT, right? We're looking at individuals with continuous high service needs that must demonstrate one of the following, right? So we're looking at either maybe they're court ordered to participate in AOT, have a high use of, psychiatric, right? 2 or more hospitalization or 1 hospitalization for 60 days or more in the past year. Now, I do want to pause here for a second as well, because those are the state requirements for ACT services. SPOA utilizes the New York City operational guidelines. So the numbers are different for us, right? So for us, for ACT services, we're looking for 4 or more utilizations, which means 4 or more. It could be a psychiatric, hospitalization. It could be mobile crisis. We're looking for 4 utilizations as opposed to 2 that's highlighted for the state, right? So we're looking also for high use of psychiatric emergency or crisis service. So FACT is similar to ACT, with the difference in being that it is better suited for individuals with criminal justice involvement and co-occurring substance use. So it's basically ACT enhanced for an individual who has criminal justice involvement, right? It's also a multidisciplinary team that also includes a criminal justice liaison, a housing specialist, and 2 peer counselors, right? It incorporates assessments that focus on criminogenic risks and recidivism. And there's additional, assistance and a FACT team that helps an individual navigate the criminal justice system. And we're looking for an individual to have criminal justice involvement within the past 12 months. So if you have someone who meets the same criteria as ACT, but let's say they're on parole, or they just committed a crime, FACT may be best suited for that individual. There's also sheltered partnered ACT, or we call it SHAT or SPACT. There's different acronyms for that one. It's just as FACT. It has the same services as ACT, but this one is enhanced services for an individual that resides in a mental health shelter. So if this person is in one of our mental health shelters, then they might be best suited for a SPAC team. And we have designated shelters that we have close collaborations with, and treatment provided to the persons assigned to a shelter or in the community. So if they meet all the requirements for ACT and they're in a mental health shelter, let's say they're in WIN or one of our other collaborative mental health shelters, you might want to put an application in for SPAC as opposed to ACT so we can have that enhancement. SPOA also deals with care coordination. As everyone knows, care coordination helps people stick with site-based mental health, substance use, and medical treatment, right? It helps someone access resources such as housing, employment, right? And peer support. And care coordinators would visit an individual at varying times, depending on their need. If they're mandated through AOT, that might be 4 times a month, right? There's a lot more information about care coordination on our website. So I invite everyone who can to just go visit our website and take a look at it. Also, there's information on the health home or managed care organization website. You can feel free to go onto those websites and get some more information about care coordination. As it relates to SPOA, we have non-Medicaid care coordination available, but the individual must have a serious mental illness, right? We're talking about, MDD, major depressive disorder, schizophrenia, schizoaffective disorder, bipolar, just naming a few of the serious mental illnesses, right? So the individual would have to have a serious mental illness and they would have to not have Medicaid. And you could submit a SPOA application through us for non-Medicaid care coordination. Now, if the individual does have Medicaid, right, we only process that their application for care coordination if they're potential AOT or they are AOT. And I'll go into what that means in terms of AOT, which stands for Assertive Outpatient Treatment, right? If they are not an AOT person and they have active Medicaid, you can go directly to the health home care and apply that way. You do not have to put in a SPOA application. As a matter of fact, we will send it back to you and say, do a ground up referral for this individual. If they have active Medicaid and they're, not AOT or potential AOT. If they are potential AOT or you're putting in the application for AOT for the individual, we ask that you just put the application before you put in your SPOA application, because that's one of the things that we do check, right? So we'll check to see if the person is AOT. And if we see that they are, then we can move forward in assignment. But if the application is still not submitted, we'll just send you we'll incomplete it and say, please submit your AOT application. So just to save you some time, just a rule of thumb, you might want to submit your AOT application prior to submitting an application for health home care coordination so that everything can run smoothly and there's no delays in the. Now we also have something called enhanced care management. So it's like a health home plus. It's an intensive health home care coordination service that's available for individuals with a serious mental illness and that are enrolled in health home, so they have active Medicaid, but there's certain high indicators of need, right, that we're looking for these individuals. We're looking for someone who has multiple hospitalizations, someone who's been incarcerated, someone who's homeless. They might have, had AOT or have a history of AOT. Maybe they have a court order in the past, or maybe they had ACT services and they're stepping down, which means they're getting better. So they need a step down from ACT services. That might benefit that type of individual. We're looking for those high indicators. And someone who's connected with enhanced care management, they get the benefits of that level of support for up to 12 consecutive months, which can be major for a client. So those, I've been mentioning AOT a lot, saying AOT, it stands for Assisted Outpatient Treatment. It's basically court-ordered outpatient mental health treatment. It's also known as Kendra's Law, right? So it's in memory of this young woman by the name of Kendra, who died in January of 1999 after being pushed in front of a subway train by a man with a history of mental illness or hospitalization. So it helps individuals with mental illness who in view of their treatment history and their present circumstances are unlikely to survive in the community without supervision, right? So they need that extra layer of supervision. And some of the eligibility requirements for this level of service is non-adherence to treatment, leading to 2 hospitalizations in the past 36 months, or maybe violence to self or others within the past 48 months. And referrals can come from everywhere. They can come from family members. They can come from anyone here on the line, care coordinators, jails, prison, treatment providers. Usually AOT includes another level of service, right? So it's AOT and care coordination, or it could be AOT and IMT, ACT, FAP, SPAT, along with it, right? So it includes another level of service. You can move forward, please.
And Ghislaine, if I can just add, one of the upcoming webinars will be to learn more about assisted outpatient treatment, because our supportive housing providers don't often apply for AOT. Community referrals to AOT do take longer. It's always best to have an AOT referral come from a hospital, but it is not uncommon for it to start in the community. And so we think it would be helpful for our supportive housing providers to know a little bit more about that process, and we'll make sure to have that be one of the following webinars that's available.
That's great. Thank you, Kathy, for highlighting that, which would be a great training. So I recommend everyone to attend that training when it becomes available. So I just kind of went over all our different level of services that we do have. I know it was a lot of information, like I stated, but it will be sent to you. So don't feel like you have to memorize everything here. And I do want to say that when you're actually completing the application, which is one of the things that I love about the Maven system, the details of the services are there on top, which you'll see later on in our presentation, describing these things for you. So if you forget, it'll tell you what's for ACT services, IMT, all of that. So it's available for you. So I'm going to, transition now to, as a clinical care coordinator, what am I looking for in an application? What are the things that are important for you to include in your application, right? One of the things that's important is the current information. I know you could be like, wow, why would it, of course we're going to put that. That's very important for us because it helps anyone that we assign a consumer to be able to find the person. Sometimes our clients are transient. They might be in Washington Square Park, even though they're housed with you, right? They might be housed in Campbell, but they often sleeping in Washington Square Park or stay at grandma's, or we want to know all that information. There's places in the application where you can put that information in. You can put the address and you can put little information as to where they are, the cross streets, the locations, so that if we connect them to an IMT team, if we connect them to an ACT team, they'll be able to locate the individual and provide that level of service. We're also looking for you guys to provide us with the observed behaviors and any high-risk behaviors, right? Does this person destroy the property? Is this person fire setting, right? Is this person physically harming themselves or others? Do they wander? Are they expressing any types of suicidal threats, or are they creating any type of public disturbances? These are all things that you can input in your application that let us know the level of risk that this person poses and help us make a determination as to what level of service would be best suited for this individual. And then there's also in the application some of the risk criteria is listed, so you can easily just check off the risk that you feel that this person is best suited for. We also want to know hospitalizations, if you have it, right? If you don't have it, we ask that you click unknown, because we do look at other systems. We do go on psyches, we do go on CrimRevs, we do go to all these other systems to verify information and just kind of get a better picture of the consumer. But if you have the hospitalizations, we ask that you put it. We actually put the frequency, the length, and which hospital that they stayed in. This also helps us determine the level that this person is best suited for. Because like I stated, if let's say you're applying for ACT services, remember for ACT services, we're looking for that level of utilization, right? We're looking for the 4 or more, right? So if let's say this person has 1, we might say, okay, there's that one, but we'll look at all the other things, but then, we might pause a little bit and then look at all the other, stuff that's listed in the application, because I do want to say that applications are reviewed on a case by case basis, right? So we look at every individual as an individual, and we look at the application in its totality, right? But we do need all the information that you have to make that level of, that's that recommendation to make that determination. So the more information that you put in, the better it is. And if we need additional information, we will email you, we'll complete it, and then put the information that we're looking for, so we can gather as much information for the individual as possible to make the best determination for the client. We're also asking for you to put contact with other providers. Maybe they are connected with an outpatient, program. Maybe they're in pathway homes. Maybe they're part of SOS or anything like that. So you want to put that information in there so that we can have it, so that the provider that we connect this individual can have it. When they're trying to support the individual, they know everything. Also, criminal justice. If you know they've been arrested, if you know their parole or any kind of open cases, you want to highlight that, because then if I'm seeing that on application, I'm saying, maybe this person may need a FACT assignment because they need that other enhancement to help support them in the community. Family contacts, right? Family contacts are important because let's say, the person stays at Campbell, but they haven't been seen in 2 days and we're trying to connect them. Maybe mom or dad or anybody else in the family may know where the person is, so we can locate the individual to provide that level of service. Now, this is another big point that I want to point out in terms of consent, right? So consent is great, but for SPOA, to submit a SPOA application, to submit the application within itself is not required, right? To submit the application is not required. Remember, once we connect them with, let's say, an IMT or ACT services, the person can, say they don't want it, and that's within their own rights. But for you to actually submit the application, right, we don't require a consent form. However, I want to put the caveat out there that if you're going to be disclosing any kind of HIV-related information about the consumer, please have a consent form, right? So for any HIV-related information, please make sure that you have an HIV consent form or redact any documentation that you're going to submit that has any HIV-related information on there. But as to just putting in a SPOA application, just putting in the application for the individual, we do not require a consent. But the person would have to consent to services later on. That's the only other little caveat. Now, we're going to transition to the information that should be included, right? I'm looking for a psychiatric and a psychosocial evaluation. Ideally, we want it to be dated within, the last 6 months. We know sometimes that could be hard for individuals to gather. I would always tell everyone, submit what you have. Submit the documentation that you have. We will reach out and let you know if we need something else. We might need an addendum. So let's say you have a very robust and detailed 2010E application for the individual. Submit that. Submit your psychosocial. If we need more information, we'll let you know. But we're looking for a psychiatric and a psychosocial. And we're looking for the information to kind of support one another. A lot of the times we get applications and you'll be surprised. One will read one thing and the other will read another thing. Will say the client is great. And then the other one will say, oh, the client is decompensating and needs a highlight. Ideally, the information should match. And if the person is refusing services, that's something that you might want to notate on the application. Any other services that has been tried for this individual or interventions, you also want to notate that. Let's say you've called mobile crisis for this person. Maybe the HEAT team has gone out and for this person already. You want to notate that. That also gives us a picture of what has worked and has not worked for the individual to let us know what service is best suited for the individual. Now, in terms of the documentation, you want to make sure that it's by a credentialed individual. In terms of credentialing, we're looking at LCSWs, we're looking like LMHCs, PsyDs, PNP, and medical doctors, right? So you want to make sure that the individual that's you're submitting that documentation has the right credential. Now, this is a part of the application that's towards the bottom end. It's called the justification box, right? So after you upload everything, you fill out the application, you get an opportunity at the bottom of the application to paint us a picture as to why you feel the individual needs this level of service. Because we're basically reading all the documentation that you're submitting, we're checking our systems, and then we're making a determination. But you know the consumer better than we do. So you see their in and outs, you see their behaviors. This is your opportunity to explain that to us. So you want to basically provide a brief statement regarding their current level of function, right? Maybe the mental health status, their relationships with family or lack thereof, any supports or no lack of support that they may have in the community, and any justification as to why you feel this person leaves this level of service. I cannot stress enough the importance of this box because it basically ties a nice bow to the application and gives us an idea of what you're seeing that you need us to see as to why this person needs the level of service. Also, in terms of supporting documentation, like I stated, we're looking for psychiatric or psychosocial. Like I stated, what you have submitted, if we need something different, we'll let you know. But a lot of the times we get social security cards, IDs, all right? Other miscellaneous documentation. We don't really require that. And I do want to let you know anything that you submit, like let's say you submit 10 to 15 documents, as a reviewer, I will have to sit and look at those 10 to 15 documents, right? Because that's part of the package. And if I want to make a great determination for the consumer, I must review all the documentation on, that you submit. So in order to avoid the delay, I would ask you just submit the documentation that we're looking for, right? The essential stuff in terms of the psychiatric and psychosocial. Just know that that justification box is another great space. If you just want to list something else, maybe you want to let me know something else, you could just put it on the justification box. You don't have to upload any additional documentation that's not needed. This is not to tell you not to, but just know that the more documentation you submit, the longer it might take to review that actual referral. So that's in terms of what, as a reviewer, that I'm looking for in an application. Now we're going to just pivot again to some case scenarios, right? We talked about the different level of service. This is a way for us to try our knowledge, right? This is a way to see what we retain so far from what I've been saying. So I'm going to have my colleague, Navalette, read the first case scenario for me. And then we're going to discuss in terms of which level of service would be most appropriate. Navalette?
Okay. So Tiffany is a 43-year-old African-American woman diagnosed with schizoaffective disorder, bipolar type. She has not been hospitalized since 2020 when she lost her job. Tiffany currently lives in a women's shelter, also since 2020, and would like to go back to work and obtain housing. She has active benefits, SSI, and Medicaid. Tiffany came to the office today to meet with the psychiatrist to complete a psychiatric evaluation for housing. While speaking with the doctor, Tiffany discussed her desire to move out of New York City and back with her family in Tennessee. Tiffany is compliant with medications and sees her psychiatrist bi-monthly and her therapist bi-weekly. Tiffany has been working very hard to secure housing and has been looking for a job in the fast food industry. What level of service would Tiffany be most eligible for and why? You can unmute yourself or place your responses in the chat. So IMT, ACT, FACT, Shelter Act, or Care Coordination?
Seeing some ACT. I'm seeing Sheltered Act. I'm seeing Care Coordination, Care Coordination, Care Coordination, ACT or Care Coordination, Care Coordination. Yeah, so for individuals that say in care coordination, I would strongly agree. Because if we break down the case, right, Tiffany is somewhat stable, right? She's meeting with her, she's attending her sessions with her psychiatrist. She's compliant with her medication, right? And she only needs assistance with basically finding a job and moving out of a shelter to permanent housing. So I would say, in terms of that, care coordination might be best suited for her because we never want to provide a consumer with more services than they need, right? So if they are somewhat stable, as Tiffany is, displaying here, you want to help them with providing with care coordination to basically help them get the other things that they need help with, and which in this case would be housing and job support. But great job, everyone. We're going to move now to Jonathan. I'll read this case scenario. Jonathan is a 24-year-old Latino subway homeless male. He was recently evicted from housing due to fire setting. Jonathan is diagnosed with a traumatic brain injury, PTSD, and borderline personality disorder. He has a criminal record for a history of fire setting, sexual assault, and has an open case for assaulting a woman on the A train with a broomstick. He is also a registered sex offender. According to the psychiatric assessment, he reported a history of mental health treatment dating back to the age of 13 at King County Hospital and reported a history of at least 10 psychiatric hospitalizations. Jonathan refuses to go into shelter and feels safer on the A train, where he panhandles and can at times become aggressive and threatening. Jonathan grew up in foster care due to neglect and states that he has been abused for most of his life. He admits to being easily agitated and aggressive to protect himself. Jonathan has care coordination, but is not connected to any mental health treatment program. The care coordinators have not been able to easily locate Jonathan, which makes it difficult to connect him to service. Which level of service would Jonathan be most eligible for and why? Once again, feel free to put your responses in the chat. Okay, I'm seeing a lot of IMT fact, IMT, IMT, IMT. Yeah, for those that put IMT, I can see why you would put IMT because of the, criminal justice history that's being displayed here. But the only caveat here is the fact that Jonathan has a diagnosis of a TBI. Remember, the diagnosis of a TBI, dementia, developmental disabilities, or personality disorder would be something that is we wouldn't assign an ACT team to. They're not best suited for ACT. So in this case, I would say IMT would be the most appropriate level of service because of the diagnosis. And also, Jonathan has a lot of high risk here, right? He's transient, he's aggressive, he's assaulting individuals, and the threats of violence. I would say IMT might be best suited for Jonathan.
So I will read the next one. Christine is a 43-year-old white female diagnosed with schizoaffective disorder and cannabis cocaine dependence. Christine is housed in HASA housing and is in jeopardy of losing her housing due to non-payment of rent, refusal of all mental health and substance use services, and states that she does not have a problem. Christine has a history of incarceration for possession of substances with intent to distribute. Mobile Crisis has been dispatched twice for her, and she has had one psychiatric admission and ER visit in the past year. Christine refuses to work with her caseworker to reinstate her Medicaid and SSI benefits and has been known to prostitute for money and substances. Currently, she refuses to leave her apartment because she owes the local drug dealers. What level of service would Christine be most eligible for and why?
Okay, I'm seeing ACT. Fact. ACT. IMT. Okay, I'm seeing a varied responses. So let's break it down, like I like to say, right? Christine has a SMI, right? So that's schizoaffective disorder and cocaine use. She is housed, but is in jeopardy of losing her house because of everything that's going on in terms of her usage. But she has a history of incarceration. Remember, for fact services, it's within the past 12 months. So a history, which means it's in the past. It's nothing current. So I wouldn't necessarily assign her a forensic act team because it's not a current. It's not something within the past 12 months, right? So that's for that. In terms of the hospitalization, she has had the mobile crisis team dispatched twice and has had one inpatient admission and an ER. So she has 4 utilizations, different services, but 4 utilizations, which would meet for ACT, right? And she refuses to work with the case manager and for Medicaid and SSI. So for me, in breaking this down, she would be eligible, let's say, for ACT services, because for those who said forensic act, because it's a history, it's not within the past 12 months. I wouldn't necessarily put her with a FACT team. I would put her with an ACT team, and just know that we have an extensive wait list. So she would probably be, waitlisted for ACT, and I would give her care coordination as an alternate level of care while she waits for an ACT assignment if she didn't have care coordination already. Just putting that out there. So we're gonna move to Darla. Darla is a 47-year-old Hispanic woman residing in Campus Scatterside Housing Program. She is diagnosed with schizophrenia and contracted HIV 16 years ago. She has a history of intravenous drug use dating back since she was in high school. She was incarcerated for 10 years due to substance-related use and is still on parole. Her case manager believes that she has returned to active alcohol and drug use and as a result stopped paying for rental stipend and can be seen dozing off at time. Darla refuses to meet with her case manager and has become hostile with her neighbors. She has even threatened to beat up her next door neighbor and has caused a lot of damage to the property. What level of service would Darla be most eligible for and why? So what are we thinking about this case? So this is Darla, 47, right? She has schizophrenia, and she has contracted HIV. So we would definitely need a consent because that's being highlighted here. I'm seeing ACT, IMT. Any other responses into what Darla would be? Okay, I'm seeing more IMT. I think you guys are 100% correct in terms of the IMT, right? There's a lot of a high-risk behavior here, the aggression, the threatening of neighbors. She's in jeopardy of losing that Scatterside apartment because of that. We don't really see, hospitalizations here, so I can't really even say for the act, but we may make a case for it because of the behaviors displayed here. But I definitely see a solid case here for an IMT assignment. Just keep in mind, because HIV information is shared here, I would be looking for a consent form.
Monique is a 38-year-old Caribbean American female who resides in a women's mental health shelter. She has been diagnosed with schizophrenia and has a history of multiple hospitalizations dating back to her early 20s. Monique has active Medicaid and SSI. She refuses to cooperate with her case manager at the shelter. Monique has been seen talking to herself and is suspicious of her peers. She believes her peers are poisoning her food and only drinks milk every day. The shelter staff have tried to encourage her to eat food that is prepackaged, but she continues to refuse. Monique has lost a significant amount of weight. She was hospitalized due to dehydration and was medically cleared, but due to paranoia, she was admitted to psych for further observation. She is scheduled to be discharged this week. What level of service would Monique be most eligible for and why?
I'm seeing some ACT, SPACT, ACT, IMT, ACT. Okay, I'm seeing a few, right? So as always, we like to break it down, right? So in terms of SMI, right, serious mental illness, Monique has been diagnosed with schizophrenia. In terms of hospitalizations, just reading this, she has been hospitalized numerous times. She currently resides in an associate women's mental health shelter, right? She definitely needs the level of service because she's refusing to eat. She's currently hospitalized right now. So just in those kind of things, I'm seeing that she might be best eligible for Sheltered Partnered Act because she's already in our mental health shelter. So that extra enhancement that the Shelter Partner Act would provide would be great for her. and she meets the eligibility requirements for ACT in terms of the SMI, in terms of the utilization, in terms of the high risk. So that this case might be best suited for Shelter Partner Act. But let's say we didn't have a Shelter Partner Act, we might assign her to an ACT team because it is depending on availability. But I would say just for that extra enhancement, I would connect her to a Shelter Partner Act team. Now we're going to read about Jose. Jose is a 33-year-old Latino male residing at Fortune Society's transitional housing residences. I know there's some people here from Fortune Society. He is currently on parole after serving 4 years in prison for assault. He carries a diagnosis of bipolar disorder and was street homeless after aging out of foster care. Although housed, he can often be seen sleeping at Washington Square Park. Jose has care coordination, but is not compliant. When he sees the worker coming towards him, he becomes irritable and begins to threaten them. Jose has had 6 psychiatric hospitalizations in the past year and states that he just wants to be left alone despite the need for behavioral health services. So in terms of Jose, what level of service are we thinking that he's most eligible for? So feel free to, okay, I'm seeing a lot of IMT. I'm seeing SPACT Act, I'm seeing FACT, right? FACT, ACT, okay. All right, IMT, SPACT, okay. So for this one, right, let's look at the housing first, right? He's housed in Fortune Society Transitional Housing Residence. It's not one of our mental health shelters. So I wouldn't say Sheltered Partner Act because he's not housed in one of our mental health shelters, right? The ones we collaborate with. In terms of a FACT, I do see a strong case for FACT here because the individual, he's currently on parole, right? He was incarcerated for 4 years and he's out, he's on parole. He has a diagnosis of bipolar disorder. He's on the street by choice, but he is housed, right? So he does have housing. He just, wanders and is on the street. He's connected to care. And he has had 6 psychiatric hospitalizations in the past year. So there's definitely a high need here. I do see a strong case for Forensic Act, right? Just because of the enhancements in terms of, the criminal risk here. I would definitely connect Jose to a Forensic Act team. I know some people said IMT, but I think what's most suited for is for Forensic Act. We can put a lot of people in IMT, unfortunately. But in terms of what best serves them is the Forensic Act in this case. So that was just some case scenarios for us to, let's say, practice some of the knowledge that we shared here. Like I said, you don't have to memorize all the criterias because as you're completing the application, that information is going to be posted on top for you, right? In terms of if you're ever doing an application, if you're ever inputting information on the application and you have problems with, entering the data or logging in, you can always email SPOA support at health. If you submitted an application, right, and you want to check the status and you don't know, you can call us. We have a number. You'll find one of our administrative assistants at 347-396-7258, or you can just email us at spoa@health.nyc.gov. And if you need assistance with tech-related assistance for nyc.gov, there's that link here for you. You can just go on the link, or you can contact the help desk here, which the number is 188-NYC-MD9 for that kind of assistance, right? I know there's some questions in the chat. We will fill out those questions towards the end of our presentation today because we're going to do Q&A at the end. But one thing I saw popping up as I was looking up is what documentation is needed for IMT. Remember, for all our services, from IMT to care coordination, we are looking for the psychiatric and a psychosocial documentation. That's for all our level of services. I just want to put that out there. Now, as promised, we've been talking a lot and engaging. And I thank you guys for participating in the case scenario section. That's how we learn, is to practice. We're just going to take a break, 5-minute break. This is your opportunity to look away from the screen. Like you, I've been staring at it for the past 40, 50 minutes or so. So this is an opportunity to look away from the screen, grab some water, use the restroom. We'll be back in 5 minutes promptly, so we're going to start back again at 2:00. And once we start back again, we're going to be doing our live demonstration. This is your opportunity to know how to complete an application right in front of your eyes. So see you guys back in 5 minutes.
Could you put the contact
yeah,
back
I'll put
up?
it on
Thank you.
Yeah, thank you so much. I'll put it also.
All right, there we go.
Welcome back, everyone. So this part of the training is going to be to show you how to create, submit, and manage your SPOA referral applications for the levels of service that we discussed earlier: ACT, FACT, Shelter Act, and IMT and Care Coordination. So the first step is to create your NYC.gov account. In order to access the portal, you would use your work email address. That's the best thing. That's the best thing to do. We ask that you not use a personal email address. If you have any issues with creating the account, if it says you already have an account and you're not able to reset your password, you can contact NYC, which we will have that information on the contact slide as well. So here is the screen that you're going to see when you go to create the account. Again, the number for NYC is 888 NYC Med 9. That is if you have any technical issues with creating a user with creating the account or accessing the system once you have created it. So here is the link that you will use in order to access the portal once your account is created. And also one other additional note is if you have an email address that ends in an nyc.gov, for example, dhs.nyc.gov, nychc.org, my apologies, then you would not have to create an account. Anyone who has a New York City account, the account itself will be linked to your email address and you would log in as an NYC employee. So I just wanted to put that out there. So here is your login screen that I was talking about. On the left side, you would use your credentials that you created. On the right side, again, if you're an NYC employee, you would just log in using your NYC email address and your workstation password. So we're going to review logging into the portal, how to begin the submission process, manage the applicants. The referral information is the screen where you would enter the client's information. And then the actual application is the Universal Referral Form. So that's going to be the name of the question package that you will be accessing to enter all of your information. There are also links that I'm going to be demoing live as well to attach your supporting documentation, and as well as once you submit the referral for review by the DOHMH SPOA team, then I will let you know what those next steps are as well. So here is your welcome screen. I'm just going to run through these fairly quickly just to give you an idea of what you're going to see when I do the live demo. So here is the manage applicants. This first screen is to enter the client's information. The next screen is the referral information, which is your information. We suggest that you make sure that your email address is written correctly here in this box. And we also suggest that you add a secondary person, for example, a supervisor or a director, just for the purposes of, if you leave the location, if you, transfer out, if you end up, separating from service, then someone else at that location would be able to access or at least receive the alerts related to the application. That secondary person would not have access to the actual referral that was created. However, at minimum, they would receive the alerts and be able to contact SPOA and provide additional information if needed. So here is, an example of the URF. These are the required sections. Anything with an asterisk is required. I'm just gonna, again, run through these fairly quickly. The utilization section, very important. And then at the bottom, you will have a button that says submit referral, and you're gonna select yes. So I'm going to pause here. And I'm going to start the live demo. So I'm just going to pause for a moment and pull that website up. Okay, so here we go. So this is what your welcome screen will look like. Here you will see the authorization. So this is the consent form. You can open it up, download it. If the client is agreeing with services or agreeing to be referred for SPOA services, then you would have them sign it, and then you will upload it back as an attachment. There's also a SPOA guide that's available for you that you can reference as you go along as well. So here, as you can see, these are the existing applications that I've already created. And this is what your view is going to look like as you create referrals. So again, the person that created the referral is the only person that would see this list and is the only person that would be able to access the application. So I'm going to demonstrate how to create one. I'm going to select SPOA referral, make sure you're selecting an adult application, and then submit a record. And then we're going to just fill in some information. So if the person has an alias, you can put that in. Make sure that the date of birth is correct. Sometimes we receive referrals where the person may select today's date and not change the year. So just keep that in mind when you are filling this in. Why aren't you working? Okay, so just for these purposes, I'm going to leave it as 2024. It's not cooperating. If you know the social, of course, provide that. The Medicaid ID, if known, you will put that in. The housing type, as far as for the address, and then you will enter the address. And please indicate the apartment number if applicable. Because, if a service provider is coming in to provide services, they need to know, if it's an apartment building, they need to know where they're going. City, we're gonna say Bronx. Leave that blank. So we're gonna hit next. My apologies, it's moving a little slow. So again, the next screen that you will see is your information, the person that's creating this referral and submitting it. So for these purposes, I'm going to make myself a housing provider. And then, are you a mental health provider? So you're going to automatically say yes, just to make sure that, that you go into the correct side of the portal and, and that there are no issues on the other end. So we're going to say test. Again, we ask, that you make sure that your email address is spelled correctly, because the system is going to be communicating directly with your email. So you're not going to receive any communication directly from the reviewer, but you will receive information from or alerts from the system, and that is how you will know, what's going on with the referral. Okay, go ahead. Next. Okay, so here is your universal referral form. As Ghislaine stated earlier, there is a brief description of each level of service. And here there is that note, if you forget or if you're not sure, there is that note for the exclusionary diagnoses for acts and facts. So at the top, you're going to see the level of service being requested. For this case, I'm going to say ACT. You don't have to specify an ACT team. If you want the consumer to have care coordination while waiting, as we stated earlier, there is a pretty lengthy wait list, citywide. So if you agree that the person, may benefit from care coordination, you can say yes. If you know that they have a managed care organization with their Medicaid, you can indicate that. If you don't know, you can leave it blank. Does the client have care coordination? You can say no. And then for the education, you can fill that information in as known. If you don't know, there's always the option for unknown. Again, the sections with the asterisks are required. So I'm just going to fill these in quickly. As you can see, the information that you enter for the client at the front screen is auto-populated here. The Medicaid ID number is populated here. So because you filled this in, you must answer this question and say no, because this is auto-populated. If you don't have access to psyches, you would say no, that you did not check psyches. For a secondary contact, you may put mom here, and then put mom's phone number or, the case manager's number, whatever information that you have that may, assist with supporting the consumer once they have services in place. For AOT, if you don't know, you can say unknown, or you can just say no. For the history, you can say no or unknown. For criminal justice, just, in the interest of time, I'm going to say probation. And then for employment, we're going to say none. Income resources, we're going to say unknown. No, we're going to say SSI. And then current living situation. So we're going to say supportive housing. And then we're going to say scatter site, right? So I'm just going to write in here, 1, 2, 3. Main Street. And then where did the person live prior to the housing situation? We can say shelter. The current location. If they are back in the residence, you would say community because they are back in the community. If they're not hospitalized. And then the last known location, you can say, what's the park in the Bronx? You can say Van Cortlandt Park. Way to 43rd Street. Okay, so you can add that because if that's the frequent hangout. So I'm going to move down now to the diagnosis section. So you can just put it in the search bar.
Now, I know you guys are not seeing that search bar come up for you guys because of the demo. But when you do click it, you will let's say you put SCH, you'll get schizophrenia, everything with SCH.
I start to see this, right?
Yes,
that it popped in. Okay, so I searched for it and now it's there. If you don't know what the diagnosis is, you would select unknown, but again, it is required, to put as much information as possible. So we're going to say there are no physical ailments. And then medication adherence. So we're going to say sometimes takes as prescribed. Are they connected to a clinic? At this time, we're going to say no. Co-occurring disabilities, we're going to say no. Hospitalizations. So I'm going to say yes. And then I'm going to say one encounter. And then I will go back to November 2023. I'm going to say November 6th. I'm going to say DB, length of stay, 2 weeks. Then we're going to say ER. November 3rd. No, I said October. Okay, we'll leave it at October. 0. So I'm just going to mix it up a little bit and say mobile crisis. Let's say, he's at the residence and, he's displaying some behaviors and you end up activating mobile crisis. We're going to say he had 2 instances of mobile crisis, and then we're going to indicate those dates. Then we're going to add an additional one. So if you want to add an additional hospitalization, you would click on add new. If you want to add an additional ER, an additional, any of these instances, you would click on the add new button, and then you would indicate that date. And so health programs, we're going to say unknown. Substance use, we're going to say unknown. Arrest, yes. Say in the past 2 years, it's looking for that information. You can say 1 in the past 2 years, and then, you can just say, I don't know. Let's say it was in July, in the summer, right? Incarceration, he's on parole, so you're going to say yes. Indicate number, we're going to say 1, indicate the dates if known. So you know what, we're going to say July. And length of incarceration, we're going to say 4 months. Right, I'm just making this up as we go along. Say November. Say he got out in October. Risk assessment. So here is where you would talk about behaviors, right? So here you can say, let's say his behaviors are escalating. You can say that he destroyed some property in the past 90 days. And then you can say, one time he did that, and then
You can select more than one on your cloud. So whatever sticks out to you. Client's behaviors, I would recommend you checking that off and then kind of speaking to it in the box below. So we can have a clear picture of what's going on.
So substance use, we're going to say no. Tobacco use, we're going to say no. Okay, so here is that justification box. So here we're going to say limited family support. Utilization. That's just people. Okay, so clearly I have a lot of typos. My apologies. So again, here you can, you can add, a lot of detailed notes, but in the interest of time, I'm just briefly describing, but you can fill up this entire box with information that's relevant to the consumer, and that will support and let the reviewer know what the needs are, and and why you think that they need the level of service that you're referring them for. So this last section here is the recommended services. And let's just say the person, they're young, and, when they're stable, they're actually interested in additional services. Then, there are additional services. There's a brochure that is available within the portal, and you can receive additional information outside of the SPOA system, about those different services. But for now, I'm going to say no, that they're not interested. And then the next question is going to pop up. Are they interested in a job? And then, you can answer that question and say yes or no. Just for the interest of time, I'm just going to say no for this individual, because as you can see, if you say yes, then something additional pops up. And then at the bottom, you're going to see requested documents. So as just stated earlier, the consent and release form. So the consent is not required to submit a SPOA referral. We can receive it, review it, and assign it. And the consumer does have the right to refuse the services once the team or the provider reaches out to them. Excuse me. So the psychosocial and the psych eval, those two documents are required. The HIV consent is only required if you disclose HIV related information. Again, you can redact that information from the documents, and then if it's not seen by the reviewer, then then it's fine. But if you disclose any of that HIV information in your documents, then they will send it back to you as incomplete and ask for the HIV signed consent. So then we're going to hit next. And then here is your dashboard again. So here is your active record that we just created. And then as you can see, we haven't attached anything yet. So we're going to go to attached documents. We're going to add a document, choose a file. So this is just a sample of, a psych eval. You're going to select it, and then you're going to give it a name. So we're going to say psych eval and hit save. So now when you look at your attached documents, that document that you attached is here. So that's kind of your checks and balances to make sure that when you look at the bottom of the URF, that you've attached everything. So let's pretend that this is a psychosocial, the psych eval, and the consent, everything is attached. Let's pretend, right? So everything is, all the questions, all the required questions are answered. All your referring information is answered as the referral source. So all of that is answered. So this status, that's what this part of the status means. It just means that you have answered all of the required questions that the system is looking for. Now, this button here, well, actually, no, I'm going to go back. So again, we're going to just make sure, that you check off, make sure you review it and say, okay, I added everything. And then when you come back here, you say everything is here, you're going to submit your application. So then a question is going to come up. Once you submit your application, you will no longer be able to make any changes. Are you sure? So this is your last opportunity to open up the referral information and make sure that your email address is correct, your phone number is correct, your contact information is correct. This is your last opportunity to review the Universal Referral Form. Let's say while you're working on the application, it took you a couple of days, and let's say you activated EMS last night, you can add that additional, ER visit or, that additional activation onto the Universal Referral Form before you submit it. And then you can hit submit. So we're going to say, okay. And then as you can see here, Mr. Brown is now added to our list. So I'm going to go to Linda. My apologies, give me a moment. Okay. So let's just say, you sent in a referral for Mr. Smith, and it was reviewed and it was marked incomplete. So now you receive an alert, which I'm going to show you a sample of those alerts in a moment. So you receive an alert from the system that says there's a change in the status of your URF. The alerts that you're going to receive are not going to have any identifying information. It's only going to have there's a change in the status of your URF, and it's only going to have the record ID. So that is where you will have to log back in, cross-match the record ID with the email alert that you received, and that's how you know which referral you're receiving the alert for. So here, you see here the status says incomplete. So you're going to go into the URF, the Universal Referral Form, go all the way to the bottom. And this is where you're going to find the notes. So here is where the reviewer is going to select what's missing. So they're going to say the attachments are missing, the psychosocial and the psych eval is what they're asking for. There's also a notes box that will pop up here, and that's what will tell you exactly what is missing. And once you add the documents and everything that's being requested, then you will come back here and you will hit resubmit and hit yes. And then you will save it. And now it has been resubmitted. So I'm going to show you the samples of, the alerts, and I'm going to show you the sample of, what those notes look like. So this will conclude, the live demo. I hope that it was helpful. Just give me a moment. I'm going to go back into the slides. Okay, so again, like I said, when you submit a SPOA referral application, it is reviewed. Once they mark it incomplete, they will set the status to incomplete, and then it will not be reviewed again until you have hit that resubmit button. You will follow the next steps, to make the necessary updates and then resubmit as I demonstrated. Just one note here is that all incomplete applications close automatically 90 days from the date that it was created, not submitted, or marked incomplete. So sometimes people will create an application, they'll create a record and they'll say, oh, I'm going to submit this referral for, John Doe, and I'm going to submit it for him and I'm going to get it started. And then let's just say, he starts doing well, he becomes stable, or he ends up, moving out or transferring out from the location. Then they can't finish the application for whatever reason. Once that record is created, it is created and it's in our system. However, it will close automatically in 90 days if it is not completed and followed up and submitted. So I just wanted to make a note of that. Here is a sample of the email alerts that you're going to receive. Again, everything is, it comes from the system. It's just going to say there's been a change in the URF status, and it's only going to give you your record ID, and then it's going to prompt you to log into the system with the link, and then you will cross-match the record ID with your list, like I said earlier, and then that's how you will know which record it's referring to. And once you've made all of your updates, you will resubmit. So here is a sample of what that screen actually looks like when there are notes added. So here is where the reviewer will have all of their notes. So they're going to say, please attach an updated psychosocial and psych evaluation. Client is ineligible, for ACT. Do you have additional information? The address is incomplete. Do you have, the complete address? Do you have the correct information? So here is the box where the reviewer is going to communicate with you what is needed in order to move forward with the process. So here is an example of an assignment notification. This is when, let's say, for example, your client has been assigned to care coordination while waitlisted for ACT. So you're going to receive 2 alerts. One is going to say your referral has been assigned for services, and then another message may say your client has been waitlisted, that your referral has been waitlisted. So this is an example of the alerts that you're going to receive. Again, it only gives you the record ID. It does not give you any identifying information about the consumer. So, and here's an example of what that assignment notification looks like. This is the information that is included in it. And this is how you would reach out to the assigned provider. Let's say, for example, if it's care coordination or ACT, this is where you will find the provider's contact information. So for support and technical assistance, so if you have any problems entering data, logging in, attaching documents, you can send an email to SPOA support@health.nyc.gov. If you have any questions about a SPOA referral that you've already submitted, you can check the application status by contacting the main SPOA line, 347-396-7258, or the main SPOA email, spoa@health.nyc.gov, and provide the name and date of birth or the record ID so that they know who you're inquiring about. And then for technical issues related to logging into the system and actually getting into the actual system, you can contact NICEMed. And then for training related questions. So we do have a training email. It is spoatraining@health.nyc.gov. We know that your email addresses are in the chat. So when we send out the documents, the email is going to come from that SPOA training email. If you have any questions, or if you didn't get a chance or are not able to put your email address in the chat, then you can send an email to the SPOA training and I will, and we will respond. Okay. So
there's a few questions already on the chat. I want to honor those questions that's already on the chat and kind of speak to those. If you have more questions, please put it in the chat or feel free to unmute yourself. There was a recent question asked about the psych evaluation, stating, can a psych evaluation be dated a year prior to the SPOA referral and a detailed psychosocial, or the psych evaluation must be months of the referral? I'm assuming the question is, can the psych eval be a little bit older than the 6 months that I kind of highlighted in the presentation? Yes, we understand that for the community, sometimes it's hard to get like a most updated psych. So if, let's say, their psych evaluation is within a year and your psychosocial is, current and has, everything that we need for the consumer, we can move forward with that. So yes, I would submit that that documentation in. Jessica also asked a question in regards to the wait list, right? Remember, I stated that at this time for most, if not all, I should say all of our services, there is an extensive wait list, right? There's different things that go into the wait list management, such as, the high risk behaviors being displayed, the level of service, and also like if there's any prioritizations, like maybe there's some of those people on the wait list that are AOT, so they get prioritized. So I can't really tell you, a person's like this person's next or that person's next, but there is an extensive wait list, and we try as much as possible to connect individuals to care as soon as possible. If you've submitted an application for an individual and you're having questions regarding where the person is or how long assignment is going to take, please feel free to email us. Our contact information is always available. And if you email us, I can connect you. You'll be connected to the person who reviewed the case, and you'll also be connected to the person who is managing the waitlist for that borough. So feel free to just email us directly. Like I said, our email information is there if you have questions regarding someone that's on the actual wait list.
Hi.
I also yes.
I'm sorry.
Go ahead.
I'm sorry. This is Daria Rosa.
Yes.
I also wanted to include that if a person's status changes, please reach out to your SPOA consultant to inform them possibly the individual was hospitalized. Maybe there's something going on at the residence that you feel would be pertinent to his case. Um, Please reach out to us. We do understand that things can change at any moment, and an individual that may be doing well today may not be doing well tomorrow. So if that status does in fact change, and if you feel that would be significant to the application and to the connection to care, please reach out to SPOA and notify us. Thank you.
Yes, that's very important, Daria. And I think you kind of pinpoint anything going on with the consumer that you think we need to know, just email. And if someone asks why the reason for the wait list is because of a lack of vacancies at the time. So we have to wait list them until a vacancy becomes available. As I stated earlier, someone also asked in regards to the required documentations, it's always going to be a psych and a psychosocial for all level of services for SPOA. So that's just keep that in mind. Let me see if there's any other questions that pop up. You can feel free
While
to
you're checking, Ghislaine, I'll just, chime in and share that this is one subset of mental health resources and mental health treatment that's available, right? What you'll find here is that these are mobile services that come out into the community, work with individuals where they are. They're not the only services that are available. And so we do want to, as we look at hosting other web series, bringing more resources to the supportive housing community. What else is out there, right? What outpatient services are available to all of you for folks who aren't this chronic or need, are willing to travel and can get to appointments on their own with the right supports. But we wanted to start somewhere with existing training that we have available right now. The wait lists are long. And so this is a big job for our SPOA team where they're constantly prioritizing, right? We prioritize people who are court ordered. We prioritize high profile cases. We prioritize requests from the mayor's office. There's a lot of different priorities that happen for different reasons. And so I don't want to discourage anyone from applying. If you have someone with a great amount of concern that you think could benefit from these services, please submit that application. What we've noted in our data when we've looked at where our referrals come from, our referrals primarily come from hospitals, shelters. Rarely are they coming from a supportive housing provider. And so this is why we thought it was really important to have this webinar here to demonstrate how to do an application, how to access the information, and think about who in your buildings and your residences could benefit from this level of care. We find, we have providers here that are both DOHMH providers and OMH providers, and on the DOHMH side, we don't have as many of the tenants connected as on the OMH side. And so, what we're finding is that the same folks are going to all the different residences, regardless of their level 1 and level 2 community care status. And so, please, if you have someone that you're thinking could really benefit from this service, bring it up to your supervisor. You submit it yourself. Try to, put as much information as you can.
I saw that someone asked about the 988 crisis line, doing a presentation. regarding that. I can't really speak to that. That's
Yeah,
just,
I could speak to that. So
okay.
so that's actually one of the next webinars we're hoping to organize for housing providers, and it's crisis services, like what's available out there when someone's in a crisis, from what 988 can offer in terms of mobile crisis treatment, which if I can quickly put a plug, if you're thinking you need a referral to mobile crisis, 988 is the number to call. It's gone through some changes in terms of, it used to be NYC well, and now we're on a national um, lifeline, 988. So what'll happen is you dial 988, you're going to get routed by your area code. So we recommend providers go online and use the online mobile treatment form, mobile crisis form. That's the fastest way to get your information in and get a referral in versus calling 988. And I'll try to locate that and put that in the chat for folks. But crisis services is one of the next webinars that we're organizing. Back to you, Ghislaine.
I
Thank you,
think
Kathy.
I think Barbara has had her hand up. Is it the same questions you left in the chat, Barbara?
Yes, I think. Okay, so Barbara, you're basically asking about a bump up. Basically, the person is connected with ACT, but they need a higher level of service, which is IMT. There is a bump up, so the person can be bumped up to IMT if they need that level of service. So yes, we do bumps up if there's a reason for it. If there's like high risk behavior that's associated and ACT is not really working for this person, we can do a bump up. Yes, the acting can submit an application for a bump up. Let me go to the next person. I see the person said, I've recently submitted a SPOA app and the psych eval is 3 years old. Since admission to supportive housing, the client is non-cooperative with program services, aggression, violent towards staff, doesn't engage, currently using substances and rental arrears. How do you suggest getting update psych if the client doesn't willingly participate or thinks they need the support? We're struggling to get an updated eval. At this point, I would advise you to, and Daria, you could correct me if I'm wrong, to just submit the documentation that we have. Like I stated earlier, we understand that sometimes there might be a difficulty in getting the most up-to-date documentation because of those reasons that you highlighted, because of the client not wanting support, not being compliant. So I would say submit what you have, submit all the documentation that we have within ourselves. We'll communicate how to best move forward. Maybe we needed an updated psychosocial, and we'll take the psych eval that you have that might be, further than, a year, dated. But I would submit exactly what you have. What would you say, Daria? Am I correct in that assumption?
Yes, I would totally agree. Submit the documentation that you have. We do utilize other systems in order to maybe access information on individuals who are being referred to SPOA services. So we may try to see if we could find additional information via our other portals. So submit what you have, and we can have these ongoing conversations about the application.
Yes, thank you for that. I see another question that says, or statement, I should say, I want to refer a client to IMT due to mental health concerns and housing being in jeopardy. However, the client does not respond to the outreaches and has not provided any documentation with a mental health diagnosis. Would it be required to have a mental health diagnosis, psych evaluation, as well as have the client's consent? So in terms for IMT service, remember, you do not need an SMI for IMT. So if you're applying for IMT services for this consumer, you do not need, the client does not need to have a serious mental illness. You just have to show that there's some, high risk behavior, there, which from what I'm reading here, there might be some high risk behavior there. So you can submit the application without having the SMI. And in terms of the consent, remember, to submit the application, you do not need consent for the consumer. Now, in terms of them accepting that level of service, they would have to consent to that, right? Once connected. But in terms of you actually submitting the documentation for the individual, that's not needed. So out of all the services that we've discussed today, IMT is the one level of service, I should say, that consent is not consent. There's no SMI required, I should
Yeah.
say.
Yeah.
Mhm.
And what I would highlight too for folks here is that, and I know this is not what y'all may be used to, these services like assertive community treatment, shelter partnered act, forensic act teams, and intensive mobile treatment are intended to work with people who may be resistant to receiving treatment, which is why it's not required to have a consent. It's almost implied that there's some level of resistance and that you're not going to get like, a signature saying, yeah, sign me up. That's the work that the teams will do once they're assigned, that individual. They're going to work to engage them in care. Um, and as mentioned, IMT, it doesn't require an SMI diagnosis, but that there's some suspected behavioral health concerns that are escalating with time and that are increasing at risk. And so I think that's wherever you can document in your psychosocial, whatever's within your control, as much information as you can offer is what's helpful to the teams, because when they get a referral and they have nothing to work with, they have nothing to work with. So being that these are housing programs and these individuals, like, give them as much information as you can about the behaviors you're seeing, what you know about the person, and that can go a long way.
Yeah, the more information we get, the better it is to make a judgment. My supervisor, Daria, likes to say the SPOA application is the beginning of a conversation. So if we have questions, we'll reach out directly. And if you have questions, you can reach out directly. Let's say we, assign a consumer to a level of service that you didn't want, and you have questions about that. You can, reach out to us. So because sometimes we may make a different assignment than what you might be looking for. So it's the beginning of a conversation. That's why I say whatever documentation you have, submit it. Don't be afraid. We're here to support you. And also, I have to say, just a little caveat, we are providing more and more services soon. Everything is still growing. We're expanding. So we're putting on peer support, clubhouses. There's so much more services that's going to be more readily available through SPOA. So don't hesitate to just, reach out and submit your applications and try to connect your individuals with care. Trying to see if there's any other questions here that I'm missing on the chat.
It looks like there are some like housing related questions. So there are multiple SPOAs, folks, and I don't want us to get confused. This SPOA is for mobile treatment and non-Medicaid care coordination and some of our rehab services. There is a CUCS SPOA for housing. And there is also the HRA housing application and their PAC service that receives applications and makes assignments and placements and things like that and schedules interviews.
If you have any questions, feel free to just put on the chat or just unmute yourself. But also, I would like for everyone to take the opportunity to fill out our training evaluation, right? We're still building out this training, and we want to make sure that it meets your needs, right? We want to make sure that after this training, you'll feel confident and comfortable in submitting a SPOA application correctly, right? So any feedback would be greatly appreciated. So we're going to put the link in the chat. It just takes like a minute or so. So we can get an idea of how we can tweak the presentation to better suit your needs, because we want you to be able to connect your consumer with the level of services that we have available. And we want to make sure that we provide you with all the information that you need. So if you do have some time, and I recommend, we have over 200 people on this chat, to just take the opportunity to just complete the training evaluation for us so we can know how to tweak this training a little bit more. Housing. So there's a question here about housing. Kathy, in terms of.
Yeah, no, so this training is not about doing an application for housing, so I just want to make sure we're not confusing folks. The DOHMH SPOA handles the referrals for mobile treatment, non-Medicaid care coordination, and some of the rehab services mentioned. If you're interested in doing a housing application, you can go to the CUCS SPOA and or HRA website, the HRA PAC system, CAP system, and they'll point you in the right direction based on the type of housing that you're looking for. They're the single point of access for that.
Thank you, Kathy. So yeah, the link has been put on the chat for the training evaluation. If you haven't done so, please do so. We want to thank you guys for being a great audience, very captive, very responsive, especially in the case scenarios. Like we said, if you have questions regarding this training, we have a designated email, which is spoatraining@health.nyc.gov. Please feel free to just send an email. Let's say you didn't get the documents. We're going to collect all the emails that's on the chat and send out the documentation. But let's say you, for some reason, your email was missed. Please feel free to email us. If you have a question regarding the training, something that's lingering that you forgot to bring up, you can also shoot an email to the SPOA training@health.nyc.gov. We hope that you got a sense of what we have to offer at SPOA. And we're hoping that we see more applications from supportive housing because we want to be able to connect as much consumers to care as possible. But thank you so, so much for everyone. And if you can just fill out the SPOA training, I'll be greatly appreciated. And I'm here to answer any questions either in the chat or on camera.
Thank you. Bye.
Oh, thank you.